Good morning friends. Today we are going to discuss prolonged PR interval, which is also called first degree AV block. We know the normal PR interval is 0.12 to 0.2 seconds. That means 3 to 5 small segments or up to 200 milliseconds. So if the PR interval is more than 200 milliseconds, this is called first degree AV block. All of us have seen ECGs with first degree AV block, and most of us consider it as a very benign condition because most of the time first degree AV block is at the level of AV node and it is mostly asymptomatic and it can be physiological also. So for us it's a benign condition. But is it truly a benign condition? It has been seen that if you have a first degree AV block in electrocardiogram, then the risk of atrial fibrillation is increased by 2-fold and the risk of pacemaker implantation is increased by 3-fold, because this AV block, or what we say prolonged PR interval, since it's a time interval between the onset of atrial depolarization to onset of ventricular depolarization. So the PR interval can prolong due to delay in the atria, due to time delay in the AV node, or due to time delay in his Purkinje system. The delay can occur anywhere. So if the delay occurs in the his Purkinje system, then such kind of AV block or first degree AV block is likely to progress to higher grade AV block or complete heart block. Then in such cases you will be requiring pacemaker. So pacemaker implantation in the case of first degree AV block is increased by 3-fold and overall mortality is increased by 1.4-fold. So it is a benign but not a truly benign condition. Now we will discuss what are the causes of first degree AV block. So what I have done, I have taken this whiteboard for this, and we have divided the causes into two categories: the intrinsic factors and extrinsic factors. Intrinsic means the causes lie in the conduction system itself, and extrinsic means there are external factors which are affecting the conduction system. Alright. So in intrinsic, I have used the mnemonic CIMS, SIMS. What is the mnemonic? SIMS. C stands for congenital heart disease. So congenital heart disease such as double outlet right ventricle or Epstein anomaly, where the anomaly is at the region of the AV node. So Epstein anomaly is, there is tricuspid valve, mostly septal leaflet, which is not placed accurately. So it is actually abnormally inserted and it is shifted into the right ventricular apex. So there is atrialization. There is atrialization of the right ventricle. So that means right atrium is more now, which is more dilated. So that there will be a delay in the right atrium. There will be atrial delay. The conduction will take time to travel through the right atrium. So the PR interval will prolong. Okay. So C stands for congenital heart diseases. C also stands for catheter ablation. So like when patient has PSVT and you are doing a catheter ablation for fast pathway, then the impulse will travel through the slow pathway. So the AV node will prolong a little bit, conduction will prolong, so thereby increasing the PR interval. So after C comes I. In I have put a star on idiopathic. So basically as you age, there is a idiopathic fibrosis of the conduction system, fibrosis and calcification, and this is the commonest cause of first degree AV block. So idiopathic is the commonest cause, that's why I have put a star. And in idiopathic you must have heard of Leaves and Laligre's disease. These are two types of diseases based after the name of their originators, and they basically represent fibrosis and calcification of the conduction system, especially around the AV node. So they will increase the AV conduction time at the level of AV node, so PR interval will prolong. So I for idiopathic, I for infarction, myocardial infarction, I for infections, and I for infiltration. So myocardial infarction, especially inferior wall myocardial infarction, has been associated with the first degree AV block. And it has been seen that the first degree AV block is seen in less than 15% of the cases of myocardial infarction. And the block luckily is mostly at the level of AV node, not below down. And in most of the cases, that means more than 90% of the cases, right coronary artery is the culprit, and in 10% or less, left circumflex is the culprit. Now, how do we recognize that this block is at the AV node and not below his bundle? So that is looking at the QRS complex. So if there is first degree AV block and along with that there is QRS widening, that means possibility of this block is below the his bundle, and this kind of blocks should be followed up regularly, and we should keep a close eye on them because they are likely to progress to higher grade AV block or complete heart block. So after the infarction comes the infection. So infection can also affect at the level of AV node and prolong the PR interval, such as infective endocarditis, tuberculosis in India, which is very common, and recently COVID. In COVID we have seen PR prolongation. Then we come to in carditis, that is mostly seen in children. Okay. And then we come to infiltration. So infiltration means some granulomatous deposits, something is infiltrating, is getting deposited in various places and including heart and conduction system. The example is sarcoidosis. It has been seen that in cases of cardiac sarcoidosis, 25 to 30% cardiac sarcoidosis will have first degree AV block. That means prolongation of the PR interval. So C for congenital catheter ablation, I for idiopathic, infarction, infection, infiltration. Then we come to M. M is myocarditis, such as rheumatic myocarditis. If myocarditis is rheumatic, we especially see prolonged PR interval. And S is for SLE. SLE is an autoimmune disorder, and this is also associated with first degree AV block. Now we come to, so these are intrinsic factors, SIMS. And then we come to extrinsic factor. So in extrinsic factor, most of the time it is meds, MEDS meds. M is for metabolic causes, E is for electrolyte disturbances, D is for drug induced, and S is for physiological sleep or excessive vagal tone. So in metabolic, the common cause is hypothyroid. So in hypothyroid patients, we may get first degree AV block. In electrolytes, hyperkalemia, hypokalemia, hypomagnesemia can cause a first degree AV block. In drugs, it is A, B, C, D. So A is for adenosine. They are all acting at the level of AV node and prolonging the refractory period of the AV node, thereby increasing the PR interval. So A is for adenosine, amiodarone, beta blocker, C is for calcium channel blocker, D is for digoxin. Simple way to remember, isn't it? So, and then S is for sleep. So if you are sleeping, your vagal tone is high and your AV node is like slowed down because of the vagal tone. But AV node is actually richly innervated with parasympathetic, sympathetic innervation, and that's why it has got parasympathetic and sympathetic have tremendous influence on the AV node. So during excessive sleep or vagal tone, such as in athletes, they have sinus bradycardia also, and first degree AV block also, and hypersensitive carotid sinus. So these are the meds, are the extrinsic causes for first degree AV block. So by this mnemonics, I think intrinsic SIMS and extrinsic meds you can easily remember and keep remembering in future also the causes of first degree AV block. Now I am going to show you some ECGs, because this is after all an ECG class. So if I don't show ECG, the exercise will be futile. Now this is a simple first degree AV block. So this is naturally at the level of AV node because the QRSs are narrow, and you can see this is P wave and this is QRS, and there's a long PR interval. Okay, normally it should be just small 5 segments maximally. Here you can see, if I calculate from here, like this only 5, this is more than, this is almost 3, 6, 7, 8, and this is 9, almost 10 small segments in between, right? So it's a big first degree AV block. This is how idiopathic first degree AV block looks like. Now the next is Epstein's anomaly. This is a picture of Epstein's anomaly. Now this is right ventricle, right atrium, left ventricle and left atrium. Now look at the mitral valve. Here is the insertion of the mitral valve. And look at the tricuspid valve. The septal leaflet is there is so much of gap like this. It is so much shifted apically. It should have been like here, but it is so much shifted apically as compared to mitral valve. So what has happened, and this tricuspid valve is like a sail, this anterior leaflet. So what has happened is the atrium is dilated, right atrium. Even the right ventricle is slightly dilated, but right atrium is huge, and there is atrialization of the right ventricle, because the whole atrium, like part of the atrium, has actually inserted into the right ventricle. So this is an Epstein's anomaly. Now what will happen in the ECG of Epstein anomaly? The ECG is likely to show a right axis deviation, right ventricular, like right bundle branch block kind of pattern. There will be tall P waves suggesting of right atrial enlargement. Sometimes they are so tall that they are called Himalayan P waves. And then there will be first degree AV block, because right atrium is so huge that the conduction time through the right atrium will increase, thereby prolonging the PR interval. Now in this ECG you can see that there is a right bundle branch kind of pattern, and there is first degree AV block. Okay, this is the first degree AV block. The PR interval is certainly more than 5 small segments. It is almost 7 small segments. And there is rightward axis. You can see there is a S wave, and there is positive waves in 2 and 3 NAVF. So rightward axis, and there is some fragmentation of the QRS. You can see QRS is looking little bizarre. Here is RS, and then there is again a small fragment. So a fragmented QRS is also a feature of Epstein anomaly. This is again second case of Epstein anomaly. This is how a tall P wave looks. Here I put an arrow. This is actually a P wave. Look at it. It is so tall. And then again first degree AV block. And again there is a fragmented QRS. So you can see the tall P wave. Right? You can appreciate the tall P wave. This is how a tall P wave looks in a case of Epstein's anomaly. Now I will show you the ECG of electrolyte imbalance, that is hyperkalemia. We come across hyperkalemia in clinical practice very, very often. Now this picture I have taken from the liveinthefastlane.com, and I think it's a very good depiction. In this is a hypokalemia also will cause PR prolongation. Hyperkalemia also causes PR prolongation. And this is a push and pull phenomena. In hyperkalemia you are pulling the T wave, and in hypokalemia you are actually pushing the T wave. So if I say hypokalemia, okay, so here you assume that the T wave is being pushed. So what will happen? T wave will flatten, then it will invert, and then there will be ST segment depression, and then there will be a prominent U wave. These are the features of hypokalemia. And then a little bit of stretch, because it will go like this and then like this. So little bit of stretch on the PR interval also. PR interval will prolong eventually. In hyperkalemia, what is happening is T wave is being pulled up. So T wave is pitched up. So it is a peak T wave, alright, and then it will go like this. So P will flatten, PR interval will prolong, and then subsequently there is QRS widening, because then it will go like this. So these are the features of hyperkalemia. Here is a picture of hyperkalemia, and okay, this is I think reverse. Let us. Now this is a classic picture of hyperkalemia where potassium has really risen. Maybe it would be around more than 7 here. So you can see, now here you can see the P wave. Can you appreciate the P wave? This is a P wave. So it's a huge PR prolongation. And see, QRS is bizarre and widened. So there is so much of widening, and the P wave is actually very teeny weeny. In some of the leaves you can't even appreciate the P wave, because P wave also becomes flat. So actually when a bizarre word comes in your mind, think of hyperkalemia. Okay, here you can't appreciate the peaking of the T waves because the QRS is so widened. ST segment is also like engulfed in that, so you can't appreciate a T wave here. But widening of the QRS, bizarre QRS complex, and PR interval is prolonged. This is a classic case of hyperkalemia. So now the question is, do they produce symptoms? Hyperkalemia, first degree AV block. First degree AV block is mostly asymptomatic. It will not produce symptoms. And if it is, and when you are observing the patients, mostly it is asymptomatic, but it is when it is really prolonged, then it will produce some symptoms like fatigue or pacemaker syndrome kind of symptoms. Then if the it is very prolonged, then you should consider reducing on the drugs like beta blockers, calcium channel blockers, and when you are giving drugs to persons, supposing beta blockers are really mandatory, and then you are giving patient beta blocker, a patient already is a first degree AV block, then if the patient has some bundle branch block also underlying, then you should be extremely careful while you are prescribing beta blockers, and you should follow them. Following is important. Follow them with serial ECGs, like after 6 months or so, for development of further AV block. And if they develop high grade AV block, then you will have to consider withdrawing the beta blocker. Similarly, you treat the underlying condition. You treat myocardial infarction properly, you treat electrolyte imbalance, and most of the time the PR interval will normalize. So, and in athletes and during sleep, if the PR interval is prolonging, anyway nothing is required. So most of the time first degree AV block will not require any treatment. And pacemaker implantation is required, but we are not in very extreme cases, but we are not discussing your full treatment here. So this was only for ECG. So this is all about first degree AV block. And next we'll discuss the short PR interval causes. So Jai Bharat, Jai Hind, and stay tuned.